localization. And that needle goes through the cortical bone into the cancellous bone. Now, I'll show you this technique. We did those over 900 patients. It's very easy to do. So we'll have the patient wear something loose. Now, the only reason you're seeing some of the pubic area here is I wanted to show you where we're going to be placing the needle. This all gets scraped out, with the towel. This is a gem sheeting needle that we use for biopsies, for bone marrow biopsy, which is not the same as what we're doing. We're just taking some stem cells. So I'll isolate the anterior iliac crest. So you see this outline in blue, my fingers on either side. And that's where the anterior iliac crest is at. Then I'll take 2 finger breaths from the angle, all the way, 2 finger breaths behind, make a little dot. Now, where that dot is, I'm going to put that long needle. The needle is long, but you only have to go maybe a centimeter into the cortical bone, so the needle stays, rather, stable. The reason the needle is long is that sometimes these patients have a lot of belly fat that you have to go through before you get to the bone. Because I'm looking in the audience, you don't need it because everybody here is nice and thin and everything looks good. So the point here is that with local anesthesia, this is done either with local or sedation. So with local anesthesia at 1% or 2% solution, I'll make a small little wheel in the area where I want to push the needle, 1 cc. Rub it, make sure the skin is numb. Then I'll take a longer needle and goes right through the skin down to the iliac crest. You can feel it. It goes right down to the bone. And this is nothing more than a supraperiosteal injection that we've all done. Is that you're depositing now the local anesthesia under the periosteum. The only difference is that this is the hip, the anterior iliac crest, not just the mandible. So now we have this long needle. It's very sharp on one end because you have the trephine that fits inside. And just with like putting in an awl or a screwdriver, I'm going to go through that small hole down to bone, and only going to a centimeter down below the level of the crest. Take out the stylet, put a syringe, and then pull the syringe back. So what you see now in red are the stem cells that are coming from the iliac crest and generated. So this is going to give better results than taking autogenous bone. So now I add this, take the needle out, and so what you see here, instead of making a big incision in the hip and taking autogenous bone, there's only a little dimple, and it is very little discomfort. The next day, patients are walking, riding a bicycle, there is no problem. This is much different than what I used to do, was make a big incision in the hip and take out the bone. But not only is it a simpler procedure to do, it is better. You get better bone. So all we have is a little dot. Put a Band-Aid on that and then close. Add it to my graft material and use that as my graft. So in this case, we've done now, this is with the graft, this was a bone marrow aspirin, with a sinus lift procedure. We did the stem cells, and I'm getting 40% bone, 100% viability, and most of the graft material is resorbed. So I'm really transplanting stem cells. This is what we're seeing, and you see little circles. These are vessels that are beginning to form. We have mesenchymal cells along the level of the bone. A new bone is forming, and you see that there are cells within the lacunae. So this was a simple procedure. I don't do this anymore because I have something that's even better. And what we have now is the ability to use umbilical cord stem cells. Now, I don't know how we do this in Vietnam, but in the States, when the baby is born, the doctors ask the mother whether or not they want to keep the cord. Because if they want to keep the cord, then they think this is going to be a nice area for stem cells, and they save the cord. Well, if you do that, or had done that, then you have to freeze that cord, spend the time and money to make sure that it stays frozen. We don't need to do that anymore, because we can take the red blood cells out from the cord. If the mother says, no, I do not want the cord, and the mother is healthy with no diseases, and we run through a lot of testing, then we can use the umbilical cord stem cells in order to do the graft. The nice thing about this, it's very, very safe. You don't have to worry about taking it from one person to another, because there are no markers on these cells that's going to say that this is something that you're going to have an antibody reaction to. There's no immune markers on this. So there's no problem with host graft problems. It regenerates new tissue, prevents cell death, reduces inflammation, modulation of the immune system. Very simple. So as a newborn, when a newborn has an injury, it takes a very short time for that newborn to heal, because in about 30 days you're going to get almost doubling the amount of stem cells that you have. If you're 30 years of age, it's going to take about 30 days, but you're only going to get 3,200 stem cells. If you go older than that, it's going to take many days before you start duplicating cells. So younger cells are the best way to go. So if I were to have a graft that I needed, then I would use the umbilical cord stem cells. So how do we use this? Because they're very highly differentiated, they divide, and they do all the things that stem cells should do, is they give you mesenchymal as well as hematopoietic. So if I compare the umbilical cord tissue to what I used to do with the bone marrow, I'm looking at the percentage of the mesenchymal cells in the graft. In the umbilical cord, I'm getting greater than 20 to 30% mesenchymal cells. When I was doing the bone marrow aspiration, as good as this was, I'm only getting about 0.1% of mesenchymal cells. So I have a simpler procedure, and I'm getting more stem cells into my graft. So anytime that we want to use this now for other defects, this is an excellent thing to do. So on this procedure, just to make sure it works, what I did is a sinus lift, and I call my tissue bank, and the stem cells come frozen in dry ice. I do the surgical procedure, and now this then becomes unfrozen into a liquid. I'm using a graft material. This happened to be freeze-dried mineralized bone. You can do this with potassium sulfate. And I take that liquid, that stem cell, and add it to the graft. Mix this up, put this into the sinus, and let it heal. So this is, you see the closure and the X-ray, of the graft. Now, in 3 months, we took a core biopsy. In 3 months, this is extraordinary. I'm getting new bone that's forming. Lots, see all those black dots? Those are cells within the lacunae that's occurring. And this is from the material that I just get from my tissue bank. If we look at the histology, we see more cells, we get angiogenesis, we get mesenchymal stem cells, and the bone is growing very well. Now, this is histomorphometric analysis. So the histomorphometric analysis is a quantitative analysis for the graft. Not that it looks like bone. I want to know, is it bone and is it viable? So in 3 months, I'm getting almost 40% of new bone, 100% viability, and the graft material is being restored. This is where we're going. So if you're doing all of this well, then you're doing the strategy for bone growth. You have a matrix that you want. You want something to water that matrix. These are your soluble regulators. And you need cells and the osteoclasts. So we are now working at an area where this is a paradigm shift on how we end up getting new bone. So I have good news for you. We're almost done. So now, any questions on the stem cells or why we're using that? Because it's so easy, in order to get a good result with this. So let's talk about sinus lift procedures, because everyone is doing a sinus lift now.